Hey everyone, and welcome to This Explainer. I'm putting on my scientist hat today, and together we're going to dissect one of oncology's absolute greatest challenges, pancreatic adenocarcinoma, or PDAC. For decades, this disease has been an impenetrable fortress, just completely defying our best scientific efforts. But, recent data suggests those walls are finally starting to crumble. We're going to explore exactly why this cancer is so notoriously difficult to treat and how a wave of astonishing new biological breakthroughs is totally rewriting the rules of precision medicine. So let's dive right into this. To understand the cure, we really have to understand the enemy first. Why is it that a disease responsible for tens of thousands of deaths every single year seems to just brush off therapies that work absolute wonders in other types of cancer? Well, the answer isn't a lack of trying. It's a matter of incredibly hostile biology. Here is our scientific curriculum for the next few minutes. First, the pancreatic cancer fortress. Second, cracking the KRAS code. Third, Daraxonrasib. Fourth, engineering immune memory. And finally, emerging multimodal treatments. Okay, let's start with section 1, the pancreatic cancer fortress. Let's step up to the chalkboard for a second and examine the tumor microenvironment of pancreatic cancer. If we actually want to understand why standard therapies fail, we got to look at the neighborhood these cancer cells build around themselves. Pancreatic cancer is characterized by what scientists call an immune desert phenotype. Basically, imagine a fortress surrounded by this massive, dense wall. This wall is the stroma, a super thick, fibrous tissue that the tumor builds. It acts like a physical shield, literally stopping drugs from penetrating. But it's also an immunological shield. There are almost no functionally active immune cells inside this fortress. Standard immunotherapies work by taking the brakes off your immune system, right? But you can't release the brakes on an immune response that was never there in the first place. Now, this whole situation has led to some pretty profound therapeutic pessimism in the field. As Dr. Joshua Dada so perfectly described it, trying to get these tumors to respond to standard immunotherapy has felt like a mission impossible. But hey, science is all about doing the impossible, right? The goal now is precision dissection, identifying the exact biology of this fortress so we can figure out how to turn it into an immunotherapy receptive condition. Moving right along, section 2, cracking the KRAS code. To actually breach this fortress, we've got to zoom way in, from the tissue level right down to the cellular level. We need to look at the engine driving all this chaos, the mutated KRAS protein. A normal KRAS protein tells a cell when to divide and when to stop. But when it mutates in pancreatic cancer, it's like a car stuck in hyperdrive with no brakes whatsoever. It just causes uncontrolled, chaotic cell division. Now, for decades, researchers tried to design drugs to stop it. But here's the underlying problem. The surface of the KRAS protein is incredibly shallow. It totally lacks the deep structural pockets that drugs usually need to latch onto. It's essentially like trying to grab onto a perfectly smooth golf ball. Because of this, KRAS was labeled undruggable for a very, very long time. So, since drugs can't bind directly to that smooth KRAS protein, scientists came up with an absolutely astonishing workaround. Step 1. The drug, Daraxonrasib, binds to a completely different helper protein first, called cyclophilin A. Think of it like attaching a piece of molecular Velcro. Step 2, this new, larger two-part structure, the bicomplex, now has the exact right shape to latch onto the mutated KRAS protein, creating a tricomplex. Step 3, the engine is completely shut down. And this brilliantly illustrates how we finally bypassed that smooth surface. Which brings us to section 3, Daraxonrasib, a clinical breakthrough. So it's one thing to have this elegant, microscopic mechanism, right? But the ultimate test is what actually happens to real patients. In the phase 3 RASolute 302 trial looking at previously treated metastatic pancreatic cancer, standard chemotherapy offered a median overall survival of 6.7 months. Daraxonrasib extended that to 13.2 months, literally doubling the survival time for these patients. To put that into perspective, that translates to a massive 60% reduction in the risk of death compared to standard care. This is a monumental shift in the second-line setting for a disease that has fiercely resisted targeted therapies. The drug penetrated that dense stroma we talked about earlier, directly challenging all of our assumptions about the pancreatic cancer fortress. Honestly, the clinical community was stunned. Dr. Asfar Azmi noted that seeing this level of activity is remarkable, pointing out that we haven't seen anything like this in the last 20 years of pancreatic cancer research. These results were so profound that the FDA rapidly permitted an expanded access program. This allows eligible patients to receive the investigational drug right now while it undergoes standard regulatory review. All right, Section 4, Engineering Immune Memory. Now, what's really interesting about this next part is that while targeted therapies are breaking down the doors, we're also figuring out how to re-educate the body's own defense system. Enter autogene cevumeran. It's a personalized mRNA vaccine custom-built from the unique blueprints of a patient's own resected tumor. By delivering these specific tumor blueprints, scientists are engineering T cells to target specific neoantigens, directly addressing that immune desert problem. And the results? Striking. 7 out of 8 patients who responded to the vaccine were still alive 4 to 6 years post-treatment. That is an absolute outlier signal in pancreatic cancer. But here is, without a doubt, the most provocative part of this data. The immune system actually remembered. Even after these patients underwent subsequent rounds of highly immunosuppressive chemotherapy, those specific engineered T cells survived and remained active. This is a profound biological inflection point. Chemotherapy didn't erase the vaccine-induced memory. The immune response persisted. Let's move into our final section, Section 5, Emerging Multimodal Treatments. Let's see how all this builds. With the walls finally breached, the scientific community is basically bringing in the cavalry, hitting the tumor from multiple angles. Tumors are smart. When you block KRAS, they try to find an escape route by rewiring their metabolism, becoming completely dependent on a pathway called NAMPT. But by adding an NAMPT inhibitor, like the investigational drug RPT-037, alongside a KRAS inhibitor, you're essentially cutting off the tumor's metabolic fuel supply while its main engine is already stalled. This dual blockade leads to far superior tumor cell death. And, we aren't just stopping at metabolism. We're also targeting the DNA replication machinery. When KRAS is mutated, it causes massive replication stress in the cell. By combining a KRAS inhibitor with a PCNA inhibitor like AOH1996, we target this non-oncogene addiction. This creates this incredible synergistic effect, meaning the drugs work better together than the sum of their parts. This synergy is absolutely crucial because it allows for lower, safer dosing of the drugs, which is a total game changer for patients who already have poor performance status. Beyond chemical and biological agents, we're seeing absolutely phenomenal advances in radiation therapies, too. Early data utilizing alpha DART, which is a diffusing alpha emitters radiation therapy, achieved a staggering 100% local disease control rate at the treated tumor site in a pooled analysis, 100%. Even more fascinating, in one metastatic patient, introducing this local radiation led to the complete resolution of distant metastatic lesions on their PET CT scans, totally hinting at a potential systemic immune priming effect from a localized treatment. And finally, we're learning that even systemic metabolic interventions can help turn the tide. A phase 2 randomized trial took metastatic patients on standard triplet chemotherapy and paired their treatment with a medically supervised ketogenic diet, strictly limiting carbs to just 30 grams a day. This supervised dietary alteration significantly extended overall survival alongside standard chemotherapy, proving that literally starving the cancer of its preferred metabolic fuel while simultaneously attacking it with drugs is a highly viable multimodal treatment strategy. Wow, okay, we have covered immense ground today. From untangling that dense stroma and drugging the so-called undruggable KRAS golf ball with Daraxonrasib, to manufacturing 6-year immune memory with mRNA vaccines, and cutting off metabolic escape routes with dual inhibitors. These breakthroughs have undeniably rewritten the rules of oncology for one of the deadliest diseases on Earth. And it leaves us with one incredibly exciting thought to ponder. If we can finally breach the ultimate pancreatic fortress, which undruggable cancer will fall next?